Welcome everybody to today's Doctors In presentation on falls. We are fortunate to be joined by Dr. Chris Azzolino from Jefferson. We present these Doctors In workshops as a partnership between us as the Elder Initiative at the William Way Community Center and the Jefferson Department of Family and Community Medicine, and are lucky to each month have great Jefferson doctors, geriatric fellows, palliative care fellows with us to share their knowledge and resources with our attendees. And Dr. Azzolino, finishing up his fellowship year, has presented with us at Doctors In before. So Chris, it's great to have you back with us. Just a couple of quick housekeeping things. Those of you who have been part of our online webinar format, Doctors In before, you know the drill, but you have the options to submit your questions at any time using the Q&A feature that is in the bottom toolbar on your screen. There are two little bubbles that say Q&A, and there is an option when submitting your questions that you can take your name off to submit your questions anonymously if there is anything that you would rather have private. Anyone watching us on Facebook, you can put your questions in as Facebook comments. I will check that periodically. And actually, Chris, I didn't get a chance to ask you. Would you rather, is it okay if I sort of interject as questions come in? Do you want to pause periodically for questions, save them for the end? Do you have a preference?
You can interject. When I finish the slide, feel free to just jump in if there's a question, I can answer that. And then we can do more at the end too, but I'm happy to do them throughout. Excellent.
Thank you. And I did just open up the chat so folks can also put their questions in through the Zoom chat if that is easier for any reason. That being said, happy to introduce Dr. Chris Azzolino. And Chris, you can take it away.
I appreciate you all having me. Thank you, David, for the introduction. So as he said, I'm a geriatric fellow here at Jefferson. I'm finishing up, I got a few weeks left, but always look forward to lecturing to everybody here and always happy to be here. So today I'm going to be talking about falls. I'm going to just this. Oh, there we go. Okay. So for falls, I think the biggest take home, what we're going to talk about today is about the prevention piece of it. Now, that being said, I wanted to make sure we kind of went through a little bit more. So kind of talking about the prevalence, how often do falls happen? How common are they? Some of the causes and the risk factors for falls. And just so you know, I'll kind of share with you what we think of as the doctor or provider as the clinical guidelines and what we do diagnostically, what we think about, what we ask, and what we'll treat with. And the reason why I think it's important to go through all of that before going through prevention is I feel like if you understand that piece of it, the prevention then makes that much more sense in the end. So kind of knowing the whole big picture about everything. So the prevalence, and this is really about why do we care? Why are falls so important? Why are geriatricians specifically so worried about falls? So just some stats for you all. 1 out of 3 adults over the age of 65 has a fall each year. I saw there's 6 in the waiting room, so that could have been 2 of you. And so it's very, very common. If you are over 80 or you live in a nursing home, that's actually half of those people actually have a fall per year. And then of these falls that happen, all the ones that occur, about 1/3 of those falls actually need medical attention. Whether they went to the doctor or not, they should have had medical attention. So kind of showing falls are often serious and it's really could take a big toll on people. When we think of our really older patients, those 80 plus or nursing home residents, falls, especially sometimes of injuries, sometimes of not, but this is really one of the big predecessors to having a subsequent decline after. A person could be doing great on their own, and they have a fall, have a hip fracture, they're in a nursing home, and it's a downward spiral from there. So it really could be that gateway into the other side of the medical world that we know of. Complications are the leading cause of death, from the leading cause of death from injury in adults. So complications from falls are very serious, and the U.S. healthcare system spends over $50 billion on falls a year between prevention, management, treatment. So very important. One thing that we think about for a fall for an older adult is that they rarely have a single cause. In an ideal world, we like to think that somebody just tripped over a rug. And if you think about when you're in your 20s or teens or 30s, you might have had a fall here and there where you tripped, or you maybe had too much to drink or something along those lines. But when we think of our older adults specifically, we think of a lot of stuff that goes wrong that makes a fall happen, kind of this complex interaction of risk factors. And this could be someone has worse balance, worse disease, they have medications, they have side effects, they don't see as well, they don't hear as well, lots and lots of things. So intrinsic risk factors, which mean kind of risk factors that are related to a person. So we think of those changes that happen with age over time and chronic disease. So and medications. Big medications we think of are blood pressure meds if your blood pressure is too low, diabetes meds if your blood sugar is too low. So it's almost thinking you're almost like over treated. And then these age-related physiologic changes, it kind of says that as we get older, things decline over time. That's our sensation isn't as good in our feet. We don't see as well. Our blood pressure doesn't regulate as well. We don't have as much muscle mass to support ourselves and catch ourselves as well. And then there are some things that can make it worse. These are these mediating factors. So if you have an illness or a situational hazard, one thing we often think about, and this is more for like nursing homes, is, there's staffing issues. There aren't enough people. If someone is in bed overnight and in a nursing home and they need to go to the bathroom and they're ringing the call bell and the nurse can't come, they might try to get up on their own and then have a fall. So we went through these in detail, but lots of risk factors. I'll take a look, let you take a look here. Surprisingly, actually, female gender actually is a risk factor. I'm not sure why that is, but it is cited as a risk. I would say of all of these, some of the biggest ones, I'll just highlight. I'm not going to read through them all, but past fall history. If you've had a fall before, you are likely to have a fall again, the older you are. And then, we have some conditions here as well, but this use of psychotropic medications, which we'll talk about, but even think of like your medications like benzodiazepam, aka like Ativan or Xanax. Medications like that could really be a big risk factor for a fall. So some other just risk factors and things that we need to think about is really parsing out indoor versus outdoor falls. And the biggest take home that I'll say is that an indoor fall, more likely to be an older adult. An outdoor fall, more likely to be someone who's young and who's healthy. And outdoor falls, you can think of, it could be rain, it could be ice, it could be uneven ground, there could be a curb. It's an unfamiliar environment, which is why we think, typically that's more younger patients that are, if they have a fall, they're more likely to be outdoors. Whereas indoors, the environment, the rugs, the floor, if you cleaned it that day typically. So use an optimized environment, so to say. So that's where a lot more, young people don't tend to fall there. Older adults will, are more likely to fall or an increased risk of falling indoors. So medications, and this is just for your knowledge. This might just think like, oh, medications you might be on. And I'm not going to say, go run to your doctor after this and say, I'm on these medications. I want to be off. I'm worried I'm going to have a fall. What I want you to think about is more of just knowing that medications always have their pros and they have their cons. And sometimes your doctor might not be pushing you to have a perfect blood pressure or a perfect A1C or blood sugar for diabetes. They might say, I think we're okay in that, slightly high range, as long as we're not too high. And this is a lot of the reason why. So having too good of blood pressure control or too good of blood sugar control is a risk factor for falls. If you think of how you are, if you fast all day and don't eat, that's almost what you're putting yourself at. You're just very, very hungry. The low blood sugars, that could be a risk. Some meds specifically for older adults we think of are the first generation antihistamines. For what you need to know is that's Benadryl, that medication people often use to go to sleep. That is a big risk for putting older adults at falls and also confusion as well. If you've heard of them, antipsychotic drugs, these are ones that we use for like schizophrenia or bipolar, or some people have like dementia. You might have heard of like Haldol, Seroquel, Zyprexa. I just put the name brands there. Those can increase falls. We talked about the benzodiazepines, Valium, Ativan, Klonopin, if you've heard of those. Some of the dementia meds could do it. And a lot of the pain medications, if you've heard of like the narcotic pain meds, like oxycodone, Dilaudid, morphine, those also could put you at a risk for falls. And like I said, the take home is don't go and say, if I'm on a medication like this, I am concerned I have a fall. more of just something I want you to know that these meds do increase the risk, and something that maybe this would actually key you up later for maybe knowing a little extra prevention for the future as well, which we'll get to.
And Chris, just a question on, so
yeah.
on these meds, is it that they're mainly, is that a side effect is that they affect balance, or is it that they're affecting fatigue? Like, are there certain symptoms of or side effects of these medications that are typically pinpointed as increasing the falls risk?
Of course, yeah. So I'm going to go through the first two specifically, and then I'll talk about the last 5 as a chunk.
Cool.
So the first one for blood pressure control, low blood pressure, you're not sending blood to the brain as well, could make you woozy, could make you dizzy, things like that. Same of tight blood sugar control is if your blood sugar is too low, that feeling of being hangry, not eating all day, your brain is a little foggy, a little more confused. And then these last 5, I'll kind of group it all as one and kind of saying that they can just make people more confused, especially if you're older. The older brain is more vulnerable to drugs like these, and it could just make people have, that side effect of just fogginess, confusion, a little disorientation, things like that. I'm going to put a special shout out to this dementia med Aricept. This is one that we use for like an early onset, an early stage dementia. This actually can lower heart rate for a lot of adults. So that's one that we worry about for falls as well, if your heart rate going too low. We talked about these. I'm not going to go through these in incredible detail. We've kind of hinted at this already. These just changes over time. We talked about that the older adult has, and just knowing that a lot of these effects are worsened by other things. So if you're on hot weather, you're not drinking a lot of water, you're dehydrated, that could, exacerbate all of these kind of risk factors that one might have. Some medical conditions, just to know, that increase the risk of falls are if you know Parkinson's disease, or if you've had a stroke before. Those could be a risk. Specifically for stroke, I'm thinking of if you have like weakness in a leg, or you're not able to see as well. Parkinson's patients, actually, their biggest thing is that they don't regulate their blood pressure as well. So it goes super high and it goes super low really readily, which can increase the risk of falls. And something that most of us eventually will have, if we don't have yet, but arthritis. Arthritis of your hips, your knees, that could increase falls. And that's more because you just don't have the balance, the coordination, the muscle strength. It hurts to stand. You don't have that safety mechanism for your legs like you used to. And we talked about this, but the environmental risk factors of like rugs or slippery floors, one of the saddest ones. I'm a proud cat dad of 2 cats, but cats and dogs are a big risk factor for falls as well. I think of my cats, I'm walking up the stairs and they just cut in front of me. And you can only imagine, if you are a risk for falls, how that could be. So I'm going to transition now into what we think about clinically. And I'm trying to keep this relatively simple, not too much medical jargon, just more so you all have an understanding of this. But so what we should do, let's say you're seeing your doctor and you say, I'm worried about having falls. I'm worried about, I had a fall in the past. What we first want to always do is see, what are they worried about? Are they worried about tripping over something? Or are they more worried about, whenever I walk, I feel really unsteady. I don't feel safe on my feet. So kind of getting an idea, or I feel lightheaded when I stand. So knowing if it's more anxiety about falling, or if it's something they've noticed that they think will put them at an increased risk. Like my legs always hurt from my arthritis. I'm worried I have to fall. So that's stuff that we can almost catch that fall ahead of time. One thing the doctor should do is they should check your gait. Gait is what they're going to do is they have you stand up and they'll have you walk down the hallway and back. So that's the doctor watching you walk, seeing that if you're safe when you're walking, seeing your balance, things like that. Watching how you sit up and out of your chair as well. They should also check your strength. So checking your leg strength specifically, that could be having them, checking like when you're marching, how strong your legs are, how strong you are if you kick your legs out like a soccer ball. And also your balance. The way we do this is a fancy thing called the Romberg test. What we do is we have you stand up, we stand behind you, we have you close your eyes, and we see if you tilt or if you fall. That's a good sign that your balance is very off. When we specifically get worried, if you came to the doctor worried about a fall that you had, if someone had 2 falls of tripping, we get concerned. if someone had, and this is like a fall in the last year. I'm not saying 2 falls in your lifetime, more like more recently. Or if you had a fall for really bad injury. If that happened, then you should have a more, detailed risk assessment with your doctor or provider. One thing I'm going to bang home this the 4th point here. If you have no history of falls, this is in your annual wellness exam when you see your doctor, you should always be asked about falls. If you've had a fall in the past or you're worried about falls, that should be asked at least once a year for you when you see your doctor for your primary care visit. So we're going to go into the diagnosis for what we do when you come and say you've had a fall. The one thing is, I actually have so many patients that actually never actually got evaluated for a fall. They might say, I had a fall, I hit my head. This happened 4 months ago. They don't tell their doctor in the moment. So I would typically urge you all, if you had a fall, I would probably at least just send an FYI to your doctor, whether that's like sending them a message, calling them, or next time you see them for a visit, just talking about that fall that you had. And that's if you're not concerned. But if there's any bit of a concern, and we'll go through what you should be worried about, then I would call your doctor, potentially go to the emergency room. A lot of people think falls are an inevitable part of aging. This is not true. They are more likely to happen as you age, but they can be prevented. There's a lot we can do about it. And the clinician should be monitoring this with you. They should make that open door, kind of that open invite of talking about falls. So things that we'll ask, if you told me I had a fall, here's what I in my head am going to go through. I want to know what you were doing when you fell. Were you walking? Were you getting up from a chair? Were you going up the stairs? Did you trip? Did you feel woozy? We'll ask about something called prodromal symptoms. Fancy word, this kind of means, what were you feeling before the fall happened? Were you feeling lightheaded? Were you feeling dizzy? Were you flushed? Was your face all red? Were you having heart palpitations? Knowing where the fall was, like we talked about, indoors or outdoors, and what was going on around there. The time the fall happened. This is important because sometimes older adults specifically are at an increased risk of falling overnight, especially men because of going to the bathroom with their prostates. So people will feel the need to get up at 3 a.m., they're in the dark, and then they fall because they trip because they can't see at night. This is probably, though, if I had to give you one take home that would make you worry about a fall or not, I want to look at this 5th bullet here. Loss of consciousness, hit your head on the floor, or if you're on blood thinners. Blood thinners being Eliquis, Xarelto, Coumadin, or warfarin, drugs like that. If you are on a drug like a blood thinner, or you hit your head, I would call your doctor, potentially go to the emergency room. That's something that you should get evaluated immediately. Your doctor should be looking through all of your meds in detail. That's ones we talked about before that could be a risk for falls as well. And then the doctor should ask about previous falls. Has this happened before? And then this last part, having a witness is really important. Someone that saw you fall that could also describe it. Maybe you have your partner or you have a family member and they saw you fall. Bringing them to the doctor, giving that collateral information is actually very helpful as well. So things we think about for just in your environment, things that you can optimize in your home. You want to make sure you have a well-lit environment. And that might be even, making sure there's adequate lighting in your home. But also if you're getting up to go to the bathroom overnight, whatever your partner thinks, I would turn the lights on in the hallway. I wouldn't risk going in the dark, not to wake people up. It is for your safety. I would make sure it is well lit. Flooring we talked about. I actually, believe it or not, hardwood floors are actually the best. That is because rugs, they're great, but they can bunch up. You can catch your foot on them, and that could cause you to trip a little bit. That being said, you want to make sure your hardwood floors or your tile isn't slippery and not recently mopped or something. If it is, I would probably take an hour or two until that dries. Having adequate railings everywhere is so important. That's railings on the stairs. That might be grab bars in the bathrooms as well, like in the showers or by the toilet. Making sure you have something to hold on to. We talk about furniture and doors, and sometimes it actually could be hard for people if you have like a really hard to open door. We think of the typical door that's a door frame with a doorknob as the ideal, but if you have these fancy French doors you have to open up like this, that can make things a lot more difficult as well. And then from what you're wearing from a shoe standpoint, Believe it or not, the best is actually shoes with thin, hard soles is the ideal. Those thick platform sneakers or shoes are not great. You just have less of your foot is farther away from the floor. Crocs or sandals aren't great either if you're worried about falls. Believe it or not, probably walking barefoot in your home is actually better than wearing sandals or flip-flops or Crocs. And then, wearing heels is also obviously very difficult in a issue as well. When we talked about pets, and I'm not saying to give up your pets, I'm just saying to acknowledge that they could be a risk for falls. And this might be something where actually, like remember growing up, my grandparents, they had a pet dog and they were worried about falls, and they actually, would keep the dog really only on the first floor. They had a little baby gate so they wouldn't worry about the dog cutting in front of them when they went up the stairs. So just things to keep in mind. So that's what you could, some environmental things we can do. Your physician should be looking at risk factors. And we talked about these with your gait, how you walk, checking your lower extremity strip of your legs and your hips. They should also check something called your sensation and proprioception of your feet and your toes. Sensation is kind of what you feel in your toes. It should be kind of, making sure you can feel and making sure there's no wounds down there. Proprioception is the fancy term. It means knowing where your foot or your toe is in space. So if you have your foot like this, and I pull it up, and it's going up, that's your proprioception intact. But if you bring it up and you don't know what's happening to your toe, that means your proprioception is not intact. This is really big risk factor for patients that are diabetics. They are at risk of getting loss of sensation, loss of proprioception in their feet. Also, if you have some vitamin deficiencies, the big one is B12. If you eat a meat diet, you're probably fine from a B12 standpoint, but if you're vegetarian or vegan, that does put you at a risk of losing that vitamin. And we have that test, that get up and go test, which is when you stand up, you walk to the hallway and you go back and you sit down. And then we have this chair stand test where you can stand up, sit down in your chair. Fancy terms, just know that there are things that we do that to assess how we think you do. Also something called a functional reach test. You stand and you have to almost reach out and see how you do when you're standing and reaching and kind of how your balance does. So things that we can do to see how safe you are to stand on your own and to walk. Now you might be curious, should I get labs done? Should I get imaging done or things like this? What I would say is the take home is there is no bread and butter workup that we do. It has to be patient tailored based on the patient, what they're telling us, what their conditions are, what their medications are, and we kind of build that workup around them. Now, that being said, some things that we always keep on our mind are we think of your blood pressure, like we talked about. We think of anemia. So are your hemoglobin levels or your red blood cell counts, are they low? Are you dehydrated? Are you not drinking? Are you having low blood sugars? Are you having too much insulin or too much diabetic medications? Or are you not eating enough throughout the day? Things from a heart standpoint, if we worry about this causing falls, we might check some imaging like an EKG or an echocardiogram. Fancy terms, but just knowing there's ways to look at your heart. And then orthostatic vital signs. What that means is we check to see when you're sitting, we'll check your blood pressure. And then when you're standing, we'll check your blood pressure. And older adults are more prone to having a big drop in blood pressure when they stand up, which can make people woozy when they stand. And then doing some brain imaging. Brain imaging we would only do if you had a fall and you hit your head. Then we would do brain imaging just to make sure there's no bleed in your brain or anything like that going on. If you are worried about falls or don't feel balanced, we probably wouldn't do brain imaging as a first line. And then if there's any injuries, like if you hurt your hip or hurt your leg or hurt your arm, we would do imaging for that as well. And there are certain things you might say that make us worried about a heart evaluation specifically. Things I would specifically think about is if you have like palpitations really bad before you have a fall, or if you're standing and all of a sudden you just lose consciousness. That's when we get really worried about a fall. Or if you are having chest pain, shortness of breath when you're walking and you feel weak and then you fall, things that would make us think about your heart needing to be evaluated. So we're finally at treatment and prevention. And this is kind of go through what we'll do for falls and also what you can do. And it's kind of hinted on this a little bit already. And like we said, this does differ depending on what clinical setting we're in. If you're at home and you tell the doctor you fell, versus if you're in the hospital overnight and you had a fall, or in a nursing home and a fall, it's typically managed a little different. So that being said, I think the most important thing that you can do is that the preventative measures are probably the most important thing, and we'll get to those in a little bit. So the first thing for a fall prevention is really looking at your home environment. And this might be you telling the doctor or provider what your home environment looks like, or just taking a good detailed look. And we talked about this. Well, rugs, or is there a lot of clutter all over the place? Do you have a lot of stuff in your house that you're tripping over? Do you have a lack of railing? All that stuff we talked about before that you could optimize. There also, if you feel like it's hard to get out of your house or home, there are home visit programs where a doctor or a nurse or a physician assistant actually come out to people's houses and can do assessments as well. So that's something to know. If you are worried about your home environment being a fall risk, this is something you could be doing. And we talk about those environmental modifications as well. Medication wise, and like I said, I wouldn't, on your standpoint, go to your doctor and say, I want to stop all these meds, but just knowing that medications could be a risk for falls, and just knowing that your doctor, if you're having falls or you're worried about falls, should be going through these in detail. And you could always say like, oh, like, hey doc, like the meds I'm on, are any of them a concern I might fall for you? And they could tell you what they're worried about. And you can always discuss the pros, cons of those. And we talk about blood sugar, blood pressures, and the pros and cons is everything. No medication very rarely just has no side effects. There's always a give and a take. So just knowing that, some might be helpful, like, for example, the benzo medications might really help your mood, they might help your anxiety, Ativan and Xanax, but they could contribute to falls. So kind of knowing there's that pro and the con that goes for a lot of medications. One thing you could think about is if you are on a medication and you really like it, but you're worried about falls, you could say maybe we do like half the dose of this medication. So I don't have as much of a risk for falls, but I still have some of the benefit as well. So postural hypotension, that's that fancy term we talked about, or the orthostatic hypotension. What that means is hypotension is the opposite of hypertension. So it means low blood pressure. And that really means a low blood pressure when you're standing, like we talked about. So this would, for you all, present like when you go to sit up from a chair to standing, you feel woozy and lightheaded, and it takes a little to collect yourself. That's what I'm talking about specifically. So if you experience that, things I want you to know that you can do. You want to minimize dehydration. You want to drink plenty of fluids throughout the day. You want to also making sure that you get up slow and you take your time. So don't just jump out of bed, jump out of your chair and go walking. You might need to, stand up, maybe grab like a handrail or some stable furniture right there. Wait maybe a few minutes, catch yourself, feel like the dizziness has passed, and then you go about moving. So taking it really slow really could make a big difference. So foot problems and footwear. This is also something we talked about that is really important. And some of you might have a podiatrist, a foot doctor, which is also someone really good to talk about this with. But making sure, you're not wearing like Crocs all the time, or sandals, or really thick soled shoes. You want to make sure your shoes are also very tightly tied. You don't want your shoelaces untied and you're tripping over the shoelaces as well. We talked about that sensory and that proprioception, the sensation. Can you feel your feet and toes? And the proprioception, like we talked about, your toe going up and down and knowing where it is in space. And then kind of addressing any underlying foot issues you might have. So that might be like bunions or hammer toe or things like that, or the sensation. One of the best things you can do also, so big take home, if you have zoned out for a lot of this lecture, I want you to take this home right here. Exercise is exceptionally important for falls prevention. And this could be in any shape and form. Really, the best exercise is the one that you will do continuously. So whether that's an exercise class or something in your home, specifically, you want to focus on your balance and your lower extremity strength. So they have balance exercises they can do, and they can have lower extremity stuff. So getting your quads, your hamstrings, your calves, all of those muscles stronger. And if you ever wanted to know what these are, you could always, look them up on Google. You can ask your doctor, but there's always some stuff that you can do for that. Even if you say, I can't go out to do exercise classes, I have no time, there's plenty you can do from home. You can look up some stuff to do from home with bands or light weights, or even just in your chair even. There are lots of stuff that you can do that meet you where you're at. If you're also worried, us as providers, we can actually prescribe you physical or occupational therapy. That's, providers you see that can really focus on getting you stronger, and they can give you exercises as well. And if you just say, I'm worried about falls or I feel wobbly on my feet, we could easily prescribe you physical therapy to help with that. Physical therapy really focuses on that strength training aspect and that balance. The occupational therapy really focuses on like safety and little like life tricks and life hacks that you can do that might actually be pretty beneficial. So in terms of just like little energy conservation techniques or ways to get it from a chair safely. And some other classes like Tai Chi and Pilates. This is actually a board question on our medical boards about Tai Chi, believe it or not, is actually one of the best preventative things for falls for older adults. But in the end, like I said, whatever exercise you will do is the best one. I would just recommend doing something, even if it's from your chair in your living room while you're like during a TV commercial. And there are lots of stuff you can do from that standpoint. We want to always.
Can I just interject real quick, Chris? I just put it for folks on Zoom. I just put in the chat. It was actually last month our doctor is in, so some of you got this message reinforced, but was on exercise. And so talked a lot about the importance of doing those exercises for balance, for flexibility, some of what one could do with a PT and an OT. So I always like it when we get these consistent messages from multiple presentations and multiple doctors. So just want to share that.
Absolutely, yeah, coming full circle, and I think just emphasizes exercise is incredibly important. So you want to make sure your vision is also optimized as well. And you want to make sure, I would say seeing your eye doctor at least once a year, I would recommend. And they want to make sure your glasses are all adjusted as needed. The one thing I tell my patients, bifocals, those are the ones that have like the big lens and they have the little other lens here. Or the ones also that are like the clear ones that have like the sun, they be kind of like have like the sunglasses built in as well. Those could be a risk for falls. I always recommend just having a single lens glass is actually really the optimal way as well. Unless your eye doctor really, really is recommending it, I would avoid it if you can, because if you have a bifocal lens, you might look up and it's clear, and if you look down at the wrong angle, then it's all blurry and you can't see where your feet are. Two most common visual issues for older adults: cataracts, glaucoma, also macular degeneration. Just making sure that all of those are optimized of eye drops and being treated appropriately, and your vision is all where it needs to be. Because if you can't see, you don't know where your feet are, and then you're more likely to fall. We talked about heart abnormalities. We talked about what you would be worried about if something with your heart happened that would make you concerned. And, if there are concerns, this might be a reason to either go to cardiology or adjust medications. And we always talk about the importance of hydration as well. So I think this is heading towards the end, but I'm going to highlight recurrent fallers. These are people that they have done all these interventions I talked about, and no matter what we talk about, they are still falling. And the highest risk of people that this is usually going to be a problem with are Parkinson's patients. We talked about them with their blood pressure issues, and they also, they don't move their feet and their arms, as much as the regular person does. So their feet tend to shuffle a little bit, which is a big risk for falls as well. And then dementia patients. And this is more just whether it's getting up because one might be confused, or it might be because one is, not knowing where they are in space, or it might be because of medications they're on for helping with their behaviors. They are a high risk of falls as well. So we talked about, we are trying to optimize all those modifiable risk factors that we talked about. Other things that they'll do is they can lower the bed to the floor as low as possible. They can have like little sturdy mats that like the gym mats almost, to help make a little bit of a cushioned floor. I think probably the bottom two of the most important take homes though is that they should have really just close supervision of family, friends, peers, home health aides, nurses. And always just keep in mind about goals of care, about if they're going to keep on falling, then you might want to think about, is it worth going to the emergency room every single time we fall or something like that, if we know it's going to keep on happening. So kind of just keeping all of that in the back of our mind. So key points, key take homes for all of you. Just, I know it's been a bit of a presentation, but just things I want you to remember. Falls are incredibly important and they threaten the independence of older adults. So this is the gateway into going into nursing homes and rehab facilities and things like that. So just knowing how important it is just to do prevention for it. And it is very important because it's the leading cause of death from injury in the older adult population. They are typically, especially for older adults, multifactorial, meaning many different things intertwine into one that can make a fall happen. It's typically not just one thing that happens. If they have a fall, they should have their gait, their walking, and their balance evaluated by their doctor. If they have 2 or more falls in the last year or 1 with an injury, we should have a risk assessment with the doctor. The key things we want to know about are the time of the fall, if you had symptoms beforehand, the location, and then also if you are on blood thinners or if you hit your head. 2 most important things about going to an emergency room, because we want to make sure you don't have a brain bleed. And then a lot of the prevention interventions we talked about, they've been studied and they have shown that by doing a lot of this can actually prevent falls and reduce falls in the long term. So that is all I have. I will open up for any feedback, any questions, anything that anybody wanted to add.
That's wonderful. Thank you so much, Chris, for all of that great information. And yes, we can give folks some time to put their questions. If you're on Zoom, you can use the chat feature or the Q&A. Folks on Facebook, you can enter Facebook comments. One that I'll pose to get us started. I know a lot of folks, especially individuals who live alone. I know folks who use a lot of these different products for either an Apple Watch that can detect falls, or their various necklaces and bracelets. And I'm not asking to, endorse any specific products, but is that something that you generally, might recommend people to use? Are there good ones that, the medical, I imagine there are probably a lot of sort of cheaper ones. Are there ones that folks in the medical profession tend to recommend?
Yeah, my favorite, I won't mention any brands, but the ones that are like the little life alerts, like those little necklaces you can wear, or the bracelets where you just push the button and it brings 911 to your house. That is my favorite one. And that is more because it's something that's easy to put on. It's actually pretty cheap and affordable. And I've had many patients that I've seen in the hospital from like a geriatric consult service that they fall at the bottom of the stairs, they broke their hip and they can't get up. And they're down for days. So, and it eventually takes like a neighbor who finds them or a family member that's worried about them, who finds them in their house. So I always recommend for people that are worried about falls, having those little life alerts where, and any brand is fine, but the one where you just push the button and it can direct 911 to your house. That way, if you have a fall, you just push the button and they come to you. Apple Watches are great. They're just very expensive, but they do have that feature as well.
I'm also curious. I know one of the referrals that we make sometimes, Philadelphia Corporation for Aging has the SHARP program, which is their home modifications program. So one, folks should know about SHARP. You do have to be a homeowner for it, and there are some income eligibility requirements, but that they will come and do things like installing railings and grab bars and tub benches. I'm curious, Chris, if you know of other types of resources for that type of thing, for the home modification specifically.
Absolutely. Yeah, I'm familiar with the Philadelphia Corporation of Aging, PCA. And I think typically a patient can reach out on their own, but doctors, social workers can speed that process up a little bit. But they, specifically for like Philadelphia County, they'll come up to your house, they will help with just getting all of that set up for a patient. So that's the one resource I would probably take home that I will often refer patients to, that if they need more in their house, they want to get things repaired or things like that are a hazard to them. And they do home assessments. They come out, they see everything, and they see where they can help.
And anyone who's not in Philadelphia, your county area agency on aging likely has similar services. Question in the chat from Eric. Actually, two questions here. What's the most common area in the home for falls? Bathrooms, kitchens, bedrooms? And then second question, is there a specific time of day that falls are more frequent? I know Chris, had used the example of someone like getting up at night, but are there other kind of peaks where you might see greater risk throughout the day?
So for the first question, bathroom is definitely the most common, and that is because twofold. So there's often a lot of water in there, whether it's from the shower, from the sink. There's also a lot of like getting up, getting down, So you think of like getting up and out of the chair, out of the toilet. So sitting down, sitting up, and then also, there's typically a little bit of a ledge for a shower. So you feel like the bathtub shower, where you have to step over the ledge, or even the little showers, that little kind of like step. There's often, a lot of issues around those ends. And then the second one, time of the day, I would say probably most common is typically either, I would say, in the evening or overnight. So overnight, we talked about before about getting up to go to the bathroom. The evening is actually what I found common because a lot of patients will take their meds with dinner. So there's medication side effects. Also, a lot of people will take sleep medicine at that time as well, which could make people a little groggy, a little confused. Also, because it's getting darker outside as well, are probably the ones that I've seen. So, we do the geriatric consult service in the hospital, and we see, anyone that comes in who's over 65 of a trauma comes into the hospital and gets consulted for us. And we often see people always come in after we leave, AKA after 5 p.m. They very rarely come in during the day as much. So I would say evening hours and overnight are the most common time.
Awesome. Thank you, Chris. And thanks for that question, Eric. Another piece I wanted to ask about, because I guess this goes to sort of the prevention. Folks who use canes or walkers, I'll just say, thinking of a specific relative in my family who has a cane and just does not want to use it because it makes her feel like people see her as an old lady. Or I know of cases where people might have a cane, but it's the wrong size, or they're not using it on the appropriate side. Anything that you can say from sort of the medical perspective of when those adaptive devices are helpful, how to make sure people are using them correctly?
Absolutely. And I appreciate you bringing that up. That wasn't part of my talk, but also incredibly important is making sure if you need a cane or you need a walker, we always recommend to use it. What I would say is that physical therapy is probably the best way of getting evaluated to make sure it is right for you. It is the right size, you're using it correctly, you're using it safely. Typically, if you don't want to go or can't get to physical therapy, you could probably ask your doctor or the nurse that's with them. They could kind of help just give you a ballpark idea about if this is right for you or not and order a new one. But physical therapy is probably the best for that. What I found, it can be embarrassing for patients. They don't want to use a cane in public. They don't want to use a walker. They don't want to be seen like that. What I've often told patients is to blame it on me, blame it on the doctor. So I've often said things like, oh, like you can just tell them that my doctor wanted me to wear it because I had, something happened a few weeks ago. He was going to use it for the time being. You can kind of make up something along those lines and blame it on the doctor. Just say, oh, my doctor's making me, they recommended it just for my safety. You don't have to say, oh, it's because I have a risk of falling and whatnot, but you can just say, blaming it on the doctor. But there's not really a clear cut. I don't have much other, It is a big problem. I think one thing I've had is people will like bedazzle their walkers sometimes. They'll make them like fancy. They'll make them look nice. They'll get like fancy stuff on there. I've also told people to tell people, oh, I only use it when I'm going like long distances and knowing I don't need it in the house. They can always talk about that as well. But definitely tough. I don't have a magic answer, unfortunately.
I was at a Pride event last week at a senior center, and someone came to our table to get a bunch of our little like Pride flag stickers and was putting them all over her walker, which I thought was pretty awesome.
I love it.
Gonna give us just a second for any other questions to come in. But big thanks to you, Chris, for taking this time to share all of this great information with us. There was a lot of great content in this presentation for a very important issue. Congratulations to you for finishing the geriatric fellowship. It's been great having you as part of our Doctors In series this year. Oh, one more question that came in. Is it possible to obsess so much about fearing a fall that it actually increases the risk of falling? So it becomes sort of a mental thing that you're expecting a fall.
Yeah, I could say definitely. If you are so worried about falls that every time you get up, you're paranoid and just fixated on falling, that could make you just overthink things, and you just might not be, as you normally would. You might not be walking as you typically do. You might be overthinking the way you're walking. If you think about like when you've ever been to like a graduation or something when people are staring at you walking down the aisle all alone, or a wedding, it is always much harder to walk in those circumstances than it is in your typical day-to-day. That's almost how I think about it, where if you just hyper focus on it, it could make it more difficult. What I would say for that standpoint is I'd actually recommend, even if you're having that fear of falling to that degree, I actually think it'd be beneficial to still go through all the preventative stuff in terms of the physical therapy, because it's almost positive reassurance to you that I've done all these things and I, should not be concerned. I found that is a better way of kind of helping get through that a little bit.
That's great. You're welcome, Eric. Thanks for the questions. We can leave it there. Thank you again to Chris. I did want to let everyone know we take the month of July off from Doctors In, as Jefferson has a new cohort of fellows, of geriatric fellows who start for the 2023 to 2024 academic year. So they're getting oriented, but we will pick back up in August with Doctors In programming. Have some new exciting topics, also some ones that we haven't done in a couple of years. So look forward to seeing you all later in the summer. Stay healthy, stay safe, be well, happy Pride, and look forward to seeing you all again soon.